duration of exposure, and solubility of gases. According to the classification, if we classify upper respiratory tract as injury up to the vocal cord, the leading injury into the vocal cord is thermal injury, because the high efficient gas exchange in the oropharynx and nasopharynx, and it causes immediate erythema, edema, and ulceration, followed by increased production of thick mucus secretion, distal airway obstruction, atelectasis, and impaired gas exchange. After several weeks, damage to ciliary function can cause increased risk of bacterial infection. Injury to the tracheobronchial tree, on the other hand, is caused by the chemical in the smoke, and it causes some pathological alterations. As we know, the tracheobronchial tree is richly innervated by the vasoactive and sensory nerve endings, and the chemical, when the smoke, following the smoke inhalation, the caustic material causes the stimulation of these nerve endings, and they release neuropeptides, and that causes bronchospasm and release of initiate a cascade of inflammatory response. Along with the process, they produce nitric oxide that increases bronchial tree blood flow almost 10 to 15 times. That causes immediate airway hyperemia. And the reactive oxygen species and nitrogen species cause injury to the bronchial epithelium and increases causes the shedding of the bronchial epithelium and increases the exudation of the fluid, ultimately formation of the airway obstructive gas. So all these pathological changes leads to airway lumen narrowing. This is the alterations like bronchoconstriction, increased vascular permeability, vasodilatation, cellular damage, and loss of hypoxic vasoconstriction. Now, injury to lung parenchyma, it's usually delayed, and it's reflected in reduced partial to oxygen and evaluate ratio, that's hypoxemia, reduced lung compliance, and increased edema formation. The initial injury, the duration between the initial injury and the development of hypoxemia depends on the severity of the airway injury. So it's caused by the bronchial injury is related to the development of parenchymal injury. The increased pulmonary transvascular fluid flux in the same mechanism before, and the increased blood flow that causes the loss of hypoxic vasoconstriction and delivery of the activated polymer nucleoside like neutrophil and the inflammatory mediators to the lung tissue, causing neutrophil cytotoxicity, and the bronchial venous outflow drains into the pulmonary circulation. So the toxic materials from the bronchial circulation drains into the pulmonary circulation and causes histologic injury, that is decreased surfactant, impair function of the alveolar macrophage, and impair the homeostasis of the alveolar fibrinolytic action. So this is the injury to lung parenchyma, increased pulmonary transvascular fluid flux, histologic injury, decreased surfactant, imbalance in alveolar homeostasis, impaired function of alveolar macrophage, and neutrophil cytotoxicity. And the systemic toxicity is caused by the inhalation of toxic substances formed by combustion. Carbon monoxide and hydrogen cyanide are two most relevant gases for mortality and morbidity, and they cause tissue hypoxia. Carbon monoxide is a colorless and odorless gas. It's very fatal, and it has high oxygen hemoglobin affinity, almost 200 times more than oxygen. So it shifts the oxyhemoglobin association curve to the left, impair release of oxygen in the tissue, and binds with the cytochrome in the mitochondria and impair its utilization of oxygen. This is the flowchart that I have already discussed, that smoke inhalation causes stimulation of sensory nerves, release of neuropeptides, and ultimately causing coagulopathy, bronchospasm, mucus secretion, airway epithelial exfoliation, and increased airway blood flow. Respiratory injury from burns can cause, in a nutshell, that the upper airway, that can cause laryngeal obstruction, bronchospasm. In the trachea, can cause mucosal slough, infection, bronchial plugging, atelectasis, bronchospasm, and the primary bronchus, the lower tracheobronchial tree, that is pneumonia, pulmonary edema, alveolar capillary defect. So what's the clinical feature? We have to take the history, and the manifestation depends on the degree of exposure, ignition source, temperature, concentration, and the solubility of the toxic gases generated. Dizziness, nausea, and vomiting are the generalized symptoms, and we can find burn on the face, side nasal vibrissae, soot in the oropharynx, nasal passage, carbonaceous sputum. If the supraglottic above the supraglottic region involvement can cause hoarseness, stridor, respiratory insufficiency, and imminent laryngospasm. And tracheobronchial damage can usually appear at the 3rd to 5th day. They can present as dyspnea and productive cough and sign of respiratory insufficiency. Carbon monoxide inhalation should be suspected in all patients who present following inhalation injury until it is excluded by the normal carboxyhemoglobin level. And the severity of manifestation depends on concentration of carbon monoxide. If the carboxyhemoglobin level 40 to 50%, usually present with headache, confusion, and collapse. But when it reaches more than 60%, it causes unconsciousness and contortion. Cardiac symptoms are tachycardia, increased cardiac output, arrhythmia, MI, hypotension. So we should receive the patient and send the blood for complete blood count, electrolytes, blood urea, nitrogen, creatinine, lactate level, toxicology screen. ABG should be sent mentioning the carbon monoxide oximetric measurement of the oxyhemoglobin saturation, carboxyhemoglobin concentration, methemoglobin concentration, and cyanide levels. Chest X-ray usually normal in presentation. If pulmonary opacity is present in the initial presentations, then it's a marker of severe injury and worse prognosis. CT scan is not routinely advised, but it can, the RAT score, that is radiologist score, helps to stratify the inhalation injury. That is, normal is 0, increased interstitial thickening 1, ground loss opacity 2, and consolidation 3. The diagnosis of inhalation injury may be suspected based on the findings in the setting of smoke exposure, but definitive diagnosis relies upon the direct bronchoscopic examination of the airways, and that can be done through nasopharyngoscopy or direct laryngoscopy and fiber optic bronchoscopy. In this examination, we can find the clinical signs of mucosal erythema and edema, blistering, ulceration, bronchoria, febrile gas, and evidence of charring. There is an abbreviated injury score rating present, which can predict the risk and severity of acute lung injury and subsequently predict the management protocol. This is the abbreviated injury score rating of the inhalation injury. Okay, if there is no carbonaceous, we'll go to the next slide. It shows the picture. The first picture that shows there is absence of carbonaceous deposit and no erythema, edema, no bronchoria, then there is no inhalation injury. But if there is patchy or minor areas of erythema, carbonaceous deposit in proximal or distal airway, it's mild injury. In third picture, if there is moderate of erythema and carbonaceous deposit along with bronchoria, then it's moderate injury. And if there is severe inflammation in trachea, copious amount of carbonaceous deposit, bronchoria and bronchial obstruction, then it's a severe injury. And evidence of mucosal stopping, necrosis and endoluminal obliteration is labeled as passive injury. The management protocol is complex because there is no defined and uniformly accepted standard protocol. Approach varies among the burn centers and starts in the pre-hospital setting by rescuing the patient from the source of fire and limit exposure as much as possible. The initial management accompanying the traumatic and burn-related injuries should be done according to the advanced trauma life support protocol. So when we receive the patient, assessment of the patient, ABC, airway, breathing and circulation. We can assess the breathing by respiratory rate, chest wall motion, auscultation of the air movement, and information about the comorbidities if possible. So if any of the following clinical findings should be is present, then patient should be hospitalized. History of post-space entrapment, history of syncope, carbonaceous sputum, hypoxemia, metabolic acidosis, carboxyhemoglobin level greater than 50%, bronchospasm or wheezing, and facial burning. General care, after initial stabilization, transfer the patient to the intensive care unit, and the early phase treatment is focused on treatment of systemic toxicity, securing the airway, and monitoring of the complications like pneumonia, ARDS, fluid overload. Securing the airway. It's the most challenging part of the heart patient management, and it can be done with bronchodilator, vigorous airway tolerating by mechanical means and pharmacologic agents, nebulized in acetyl cysteine, nebulized heparin, and endotracheal intubation or tracheostomy. Bronchodilator is a very important drug. We know that the pathophysiology causes bronchoconstriction. So bronchodilator relaxes the bronchial muscle, decrease airflow resistance, improve dynamic compliance, stimulate the mucociliary clearance, and the useful bronchodilators are albuterol, tiotropium, and epinephrine. Nebulized epinephrine, it has both alpha vasoconstriction and beta bronchodilation effect. So the increased blood flow, bronchial blood flow, that causes 10 to 15 times increased bronchial blood flow, that can be causing the airway hyperemia and edema. At the same time, the bronchial venous outflow that deliver the toxic material to the pulmonary circulation can be minimized by using the epinephrine, nebulized epinephrine, along with the bronchodilation effect. So nebulized epinephrine reduces the airway hyperemia and improves airway obstruction. And nebulized epinephrine is superior to the nebulized albuterol in ameliorating the severity of acute lung injury in confined bar and smoke inhalation. Various studies has shown that. So airway tolerating that can be achieved by mechanical means and pharmacologic agents. Mechanical means therapeutic coughing, chest physiotherapy, airway suctioning, RE ambulation, intubation with suctioning, therapeutic bronchoscopy. And the pharmacological agents are N-acetylcysteine and aerosolized heparin. N-acetylcysteine should be given in a dose of 3 ml of 20% solution every 4 hourly. And it should be used with bronchodilator because it can cause bronchoconstriction itself. And aerosolized heparin in alternative duration. Aerosolized heparin dose is 5,000 to 10,000 units, 3 ml normal saline. Effects of nebulized heparin and N-acetylcysteine. Heparin causes, it decreases the formation of liquid gas, reduce mortality, reduce reintubation rate, atelectasis, increases survival, better lung compliance, less pulmonary edema, less airway obstruction, and significantly decrease the duration of mechanical ventilation days. Endotracheal intubation, maintaining endotracheal tube in a burn patient is very challenging because accidental removal is a concern. And the anesthesiologist, pulmonologist, surgeon, and critical care physician should decide the most appropriate method of airway management, either by endotracheal intubation or placement of tracheostomy. About 80% of burn patients require intubation for short-term management, and some patients will ultimately require tracheostomy. These are the signs. If they are present, we should consider early intubation. There is deep burn to the face or neck, blisters or edema of the oropharynx, stridor, use of accessory muscles, respiratory distress, sub and suprasternal retractions, hyperventilation, and any question about securing the patient's airway. Oxygen inhalation, it's more crucial in carbon monoxide inhalation injury. Humidified oxygen, normobaric high concentration oxygen by reservoir mask were transported to the hospital. This is recommended. If this SpO2 is 100%, even though we have to give 50 liter per minute oxygen via the reservoir mask, 100% oxygen inhalation by mechanical ventilation should be given when there is loss of unconsciousness, the loss of consciousness, cyanosis, or inability to maintain the airway. Another therapy that used to be recommended is hyperbaric oxygen therapy. It allows the carbon monoxide to dissociate from the cytochrome and increases the concentration of oxygen. Advantages, some studies showed that it's advantageous in the children treated with hyperbaric oxygen has low risk of dying, but it's no longer recommended due to difficulty of physiologic monitoring, providing emergency procedure, unstable hemodynamic condition, seizure and aspiration of severe burn patient. Patient with obstructive airway disease or OSA who are in risk of hypercapnic respiratory failure, they are low threshold to treat the patient with NIV or mechanical ventilation. This multifactorial tissue hypoxia can quickly lead them to death. This is the suggested treatment protocol for non-intubated patients. Humidified oxygen to maintain saturation more than 90%. And non-pharmacologic maneuver should be done every 2 hourly, that is cupping and deep breathing, turn the patient side to side, chest physiotherapy, and nebulization every 2 hours alternating, aerosolized N-acetylcysteine and bronchodilator, and aerosolized heparin with saline. Nasotracheal suction if needed, encourage early ambulation, and patient quality and patient education about the disease process and prognosis. The ventilation management, optimal ventilator strategy is not well defined. Use preferred mode is pressure support ventilation or volume assist control ventilation. And the tidal volume is 6 to 8 ml per kg operated body weight. To overcome the conventional ventilation challenges in burn patient, the modes are proposed in high frequency percussive ventilation, high frequency oscillatory ventilation, and high frequency jet ventilation. Among the three, the high frequency percussive ventilation is superior. So high frequency percussive ventilation, it improves the airway clearance, improves lung improvement, improves gas exchange, decrease incidence of pneumonia, and improve survival. Simple prone positioning can improve oxygenation. And extracorporeal membrane oxygenation, it improves oxygenation, immediate reduction of carboxyhemoglobin level, and cardiovascular failure is reversed. These are the extubation criteria. Partial pressure oxygen and FiO2 ratio is more than 250 millimeter mercury. Maximal inspiratory pressure more than 60 centimeter of water. Vital capacity at least 15 to 20 ml per kg. Spontaneous tidal volume 5 to 7 ml per kg. Maximal voluntary ventilation 2 times the minute ventilation. Minute volume and resolution of the need for intubation and audible leak around the endotracheal tube. Typically, tracheostomy should be done after 3 failed extubation attempts or after 21 days. These are the future therapies. Some researches are ongoing. The IV intravenous administration of antithrombin. The antithrombin is an anti-inflammatory. It has anti-inflammatory effect, and the heparin needs antithrombin for work. So, if the IV antithrombin should be concomitantly used with nebulized heparin to achieve the maximum local anticoagulant and systemic anti-inflammatory effect, and it reduces the mortality in the burn patients. Some studies shows. Bronchial artery ablation is important, reducing the airway hyperemia and inflammation, but not feasible in clinical practice. There are some cellular therapies, IV administration of adipose derived mesenchymal stem cells, human bone marrow derived mesenchymal cells. They are beneficial in minimizing the parenchymal injury and developing pneumonia. Arteriovenous carbon dioxide removal, it is successful in reducing morbidity, mortality, and days of ventilator support. These are on trial. And the long-term sequelae is the most patients do not suffer long-term functional impairment. The most rare long-term sequelae, this usually occurs in patients who had severe bronchitis and nosocomial pneumonia at the time of injury. Usually they develop in long-term tracheal stenosis, bronchiectasis, interstitial fibrosis, reactive airway dysfunctional syndrome, and bronchiolitis obliterations. Prognosis in inhalation injury is an independent predictor of mortality in burn patients. Higher cases of fatality, higher case fatality for a given box score is H plus total burn surface area compared with those with no inhalation injury.